I'm really happy to announce the first keynote of this conference, not only because of the topic, but of course also because of the speaker. Noise, even though it's so omnipresent in our modern life, it sort of still is a bit of a niche topic, even in environmental epidemiology. And so I'm very happy that it's been given really this big stage here at the conference. And who better to have talk about it than Mette Sørensen. Professor Mette Sørensen is a senior researcher at the Danish Cancer Institute and a professor at Roskilde University, and she's one of the leading researchers on health effects of noise. Among others, she has provided evidence for outcomes which have not been researched in this regard before, for example, for stroke, for diabetes, and for breast cancer, and I think she will tell us some about this. So thank you, Mette.
Thank you very much, Benedict, for this nice introduction. And also thank you very much to the organizers for inviting me. I'm really pleased to stand here today and talk about my favorite research subject, which is, of course, transportation noise and how transportation noise can affect our health. So I will start by giving you an overview of transportation noise for those of you who have not worked with this before, and then I will go into showing you some of the results that we have obtained. So first of all, how many persons are actually exposed to noise? You can say the region where we know most from are from the European Union, because we have this European Noise Directive that every 5th year, according to this, every 5th year, all the EU countries has to estimate how much noise their populations are exposed to. And in 2020, which was the last time they did this, they estimated that at least 20% of the EU population are exposed above these 55 decibels. And 55 decibels is the limit that EU estimates noise above. So EU doesn't estimate noise below these 55 decibels. And as you can see on the numbers up here, road traffic noise is by far the most, which is as expected, the source that most noise comes from. But I think it's important that when we talk about this EU estimation of noise, that to realize that it's only based on estimation in large agglomeration, which is cities where you have more than 100,000 inhabitants, and then really large roads defined in the EU as more than 3 million vehicle passengers a year. So this is what EU estimates, and that is also why they include this at least 20%, because they know there are areas where they don't estimate noise. So according to WHO, this makes noise the second largest environmental pollution in EU, only exceeded by air pollution. So why is noise at all harmful? We know that there are two important mechanisms here. First of all, it can induce a stress response. Over here, where it induces both the HPA axis, leading to increased levels of cortisol, but also the sympathetic nervous system, leading to increased levels of adrenaline and noradrenaline. But what is at least as important as this one, that if you're exposed to noise during the nighttime, it may disturb your sleep. And it's both the sleep quality and the sleep duration that are affected. If we look at kind of the sleep quality, there are studies showing that you will have less REM sleep, and even more important, you will have less slow wave sleep. And we know that this is especially important because during slow wave sleep, our body restores. So not having this slow wave sleep is really important. So these are the acute effects of noise. But what is really problematic is this chronic effect of noise. So if you're exposed to noise every day during years, this can have an effect on a number of biological risk factors. So this includes biological risk factors for cardiovascular disease. This were where the research area actually started looking at. This was cardiovascular diseases. And a number of studies have shown that noise might be related to increased risk of hypertension. There are also studies showing an association with oxidative stress, and a number of studies from Germany that showed an effect on the endothelial function, so endothelial dysfunction. And we know also that if you are exposed to noise, it has effects on the inflammatory system. It may also increase a number of risk factors for metabolic diseases, obesity, and diabetes. We know, and here we think actually that especially these effects on sleep are important, because we know that if you have a poor sleep, it will affect your insulin levels. You will have a decrease in insulin levels. It will affect the blood glucose, and it may also affect the hormones that are regulating our appetite, all risk factors for obesity and diabetes. We also know that there might be some risk factors for dementia. This includes, again, these effects on the inflammatory system. We know also that oxidative stress may be a risk factor for dementia, endothelial dysfunction, and also these effects on the sleep. And lastly, we are working at a Danish Cancer Institute, so we're also interested in effects on cancer. And here there are also some potential biological risk factors. Again, these effects on the inflammatory system, which we know can affect risk of cancer. There are this oxidative stress, and there are also some studies that have been conducted that indicate that noise may affect the circadian rhythm, which is risk factors for example, breast cancer. And then there are we know that stress and sleep disturbance may lead to a change in lifestyle. I think all of us know that, for example, if we are stressed, if we have a poor sleep, that we will change our diet. We will maybe be a bit more reluctant to do physical activity. And these are all risk factors for cancer. So what do we know about noise and cancer? The last, you can say, more comprehensive report was this one, which came out in 2018, made by the WHO. And in this report, there was a number of expert groups that evaluated all the epidemiological evidence that was there at that time in relation to a number of different diseases. But it's important to remember that when we look at this report, we know that we only have research until 2015, because it took them 3 years to do this work. So it's already kind of 9 years old, this report. But in this report, what they included was that there was a high quality evidence for concluding an association between noise and ischemic heart disease, such that a 10 dB increase in noise led to an 8% increase in risk of having ischemic heart disease. For all other diseases, which included, for example, stroke, it included diabetes, they evaluated there were either very low, or moderate quality evidence. So what about the health impact then? EU evaluates in their, every time they do their END measurements or estimations, they also evaluate the health impact of noise. And they did this in 2020 in this report up here. And you can see these are the numbers. They evaluated that at least 12,000 cases of premature death every year could be subscribed to noise, almost 50,000 persons with ischemic heart disease, and then millions of people being disturbed in their sleep, and also with high noise annoyance. But again, it's important to realize that this is based on the WHO evaluation in 2018, which is research until 2015. So I think it was very easy for us to say that we need more research. So therefore, we did a study. In Denmark, based on the entire Danish population, we included all people in Denmark that were more than 35 years of age. And then we followed up for a number of different diseases between 2000 and 2017. And this gave us a population on 3.6 million. And if you want to do epidemiological research, then Denmark is really a good place to do it because we register everything. So we have so many different registers, and in Denmark everybody has this social security card, and in this card we have this 10-digit number. This is of course an artificially generated one, but we have this number and everybody gets it at birth or when they immigrate into Denmark, and with this number we can link all our registries. So a really important registry for us is this CPR registry, where we have a complete, precise address history for all people in Denmark. And it's dating back to 1970. So this includes even moving. So if people move from one address to another address, then we have the information also and the address before and after. So we geocoded all these addresses. We sent them to a noise consultant, which estimated traffic noise. We also estimated air pollution. And then we have all these different health registries up here, a hospital registry, which every time a person is admitted to a hospital, it is recorded with an ISEE code. We have a mortality registry, of course. We have a prescription registry, which hold information on all redeemed medication in Denmark, a cancer registry. And then we also have a number of socioeconomic registries. So in this study population, we have individual level, and this is important, individual level information on income. So actually this is a yearly information, so it's even in a time varying manner included in our studies. So we know every year what everybody living in Denmark, what their income are, what their education are, whether they are cohabiting with a partner or not, their occupation and their ethnicity. So we estimated noise using the Nordic prediction method. This is an acoustical model. And input variables for this model is, of course, all the geocodes. Then we also have information on height. So for example, if you live on the 3rd floor, then we also estimate noise at the 3rd floor. And in this study, we focused on all the addresses from 1990 to 2017, which gave us a possibility to look at these 10 years averages of noise. The model also includes screening from buildings. You can see this is a 3D view of how it looks in the Nordic prediction method when it's estimated. So of course, if you live in a building behind another building, then this is calculated in. We also have information on noise barriers, so this is also included, and terrain, although it's not that important in Denmark because we are a pretty flat country, but even though we had information on terrain, we also had information on reflections. And for all road lines, as you can see here in red in this picture, we had information on the traffic composition. We know how much traffic is on these roads, the speed and the road type. And this gave us this measure of noise, LDN, which is you can say an average over the entire day, evening, night, as DEN stands for. So all the results you will see will be based on this way of estimating noise, LDN. So this is how a noise map look over entire Denmark. So basically it's all the address dots that you can see in this map over Denmark over here. And here you can see our distribution of noise. We estimate noise we say that the lowest noise we can estimate is this 35 decibel. Below that would be below kind of the background level of noise. And Denmark, as you can see, is highly density area, population density area. So we don't expect actually that anyone living in Denmark are not exposed to noise. So everybody in Denmark are exposed to noise. It's not possible to escape noise in Denmark. And I just want to show you how that compares with what EU estimates. And Denmark is actually one of the countries that are really good at estimating noise in EU because they have been focusing on this for many years. But just to show you, so what EU does is that it estimates noise at these large agglomerations, as I said, more than 100,000. And in Denmark, we have these 4 different cities where it's estimated. And then we also estimated at these large roads that you can see here. So, but you can easily see when you compare these 2 maps, this is what is reported to END, and this is what we estimate, that there are a lot of black dots on this area that are not estimated. And it's also no surprise that they find much less people exposed to noise than we do in our model. So in our study, we also, all the results basically that you have seen so far when you've been reading papers on noise will be based on noise at the most exposed facade. This is the most used proxy. But in our study, we also wanted to focus on this noise at the least exposed facade because what we thought was that this could be kind of a proxy for what you were exposed to while we sleep. Because if you live in a house or flat where you have a possibility to choose a bedroom facing away from a busy street, our hypothesis was that most people will do that. So the least exposed facade might be a better estimate of what we are actually exposed to during our sleep. And as you can see here, we didn't find any strong correlation. And what you can see in these 2 maps are noise at the most exposed facade in Copenhagen and the least exposed facade. And this is the kind of the central part in Copenhagen. And you can see Copenhagen actually becomes really quiet when we look at noise at the least exposed facade. And this is because in Copenhagen, we have these multi-story buildings facing around the closed courtyard, and actually in this closed courtyard you don't see or you don't hear that much traffic noise. So it's pretty silent, at least for road traffic noise in there. So we also estimated air pollution, of course. I won't go into details with this. This is not a topic. Just say that we use this high quality multi-scale exposure model where we estimated air pollution both at the street level, region level, and background level. And this gave us information on both PM2.5 and NO2 on all these addresses that we have estimated noise for also. So the diseases I will present results from today are the cardiovascular diseases, which we identified in our hospital registry and our mortality registry. We looked, of course, on incidence disease. And the cardiovascular diseases I will show is some heart diseases, ischemic heart disease, angina pectoris, and heart failure, and also stroke. I will show you results for diabetes. And we identified these using both hospital registry and also this information on prescriptions, dementia using also 3 different registries: hospital, psychiatric registries, and prescription registries, and then breast cancer using our cancer registry. So to the results for cardiovascular disease, they're here. And I show results here, as I said, for ischemic heart disease. Here we had 122,000 cases. Angina pectoris, here we had 16,000 cases. Heart failure, where we had almost 80,000 cases. And you will see results both for the most exposed facade and the least exposed facade. And all results are giving per 10 dB higher noise. And it's a 10-year time-weighted average of noise that we are looking at. And here you see the crude, and here you see the adjusted hazard ratios. We're using Cox proportional hazard models for this. And here you can see all we adjusted for. So as I said, these individual level socioeconomic variables, but also some area level socioeconomic variables, and of course age and sex and calendar year. So as you can see, we found a strong association actually for all these different cardiovascular diseases, strongest for angina pectoris. And for heart failure, we found strongest association for noise at the least exposed facade, which indicates that sleep may be important here. If we add in air pollution to the models, you can see that they don't change that much. So they're pretty robust to further adjustment for air pollution, which is a general trend. This is what people observe in noise studies, that they are pretty robust to adjustment for air pollution. And here you see the exposure response curves, both for ischemic heart disease here and for heart failure here. And in pink, you see results for the most exposed facade, and in blue, it's results for the least exposed facade. So in blue, this proxy for noise during sleep. And you can see, as I also showed with the hazard ratio, that especially for heart failure, it seemed to be stronger for noise at the least exposed facade. But if we focus on the pink curves here, and this is because this is where all countries actually do legislation from. So this is the most exposed facade. You can see what is important here. We actually don't find indications of any lower thresholds, especially not here for heart failure. At least it doesn't seem to be any magic limit here around these 55 decibel, which is what EU operates with. So it seems to be the more noise, the higher risk for cardiovascular disease. And if we compare our hazard ratio here on 1.04 with kind of the newest meta-analysis, including all studies that are available presently, you can see that they're pretty comparable. So this is kind of the size of the risk. So a 10 dB increase in noise increases the risk of these cardiovascular diseases around 4 to 5%. We also looked on stroke. Again, most exposed facade, least exposed facade, almost 200,000 cases. And again, if we look at the adjusted results, you can see we did find association. They were not as strong as for the heart diseases. Adjustment for air pollution here, both PM2.5 and NO2 led to some reduction, but it's still significant associations. And again, if you look at the exposure response relationship here for the most exposed facade, again, we don't see this lower threshold indicating that the more noise, the higher risk for stroke. And our hazard ratio on 1.04 is kind of similar also to the recent meta-analysis, including all, and there are a lot of studies now on traffic noise and stroke. So around a 5% increase in risk per 10 dB increase in noise. Type 2 diabetes. The results here for the most exposed facade, the least exposed facades. Again, it's a 10-year mean, and it's the results are per 10 dB. And you can see here we have more than 200,000 cases. And if we look at the results here, you can see that we found that noise at the least exposed facade, so this proxy for noise during sleep, during nighttime, was stronger, which was basically also what we expected, because we know that this with having a poor sleep is really a risk factor for diabetes. We know that from a number of sleep studies that having a poor sleep increases risk of diabetes. So this was our a priori hypothesis that we would find stronger associations here. Again, air pollution didn't affect it so much. And if we look on the exposure response relationships again, you can see here, this is a curve that you basically just dream of getting when you start to do epidemiology. So having a curve like this, where it's just so nicely linear associated. And again, here, if you look at noise at the most exposed facade, because this is what EU and basically all other studies measure, you can also see a nice exposure response relationship and no indication of a lower threshold. And our hazard ratio on 1.05 here is kind of adding nicely to what we know from meta-analysis. So I'm sure that there's a lot of you sitting here saying, well, all these findings that we have, it's just because we don't adjust for lifestyle, which is a question I have received many times. So many times that I thought that it would be relevant maybe to do a study on this. So I did a study on a cohort on almost 300,000 participants that were randomly distributed across all of Denmark. and I followed them up for diabetes. So I found 7,500 of these developed diabetes. And to the results, it's again road traffic noise at the most exposed facade. And what is important to compare is this model and this model. In this model, I have included all the socioeconomic variables that I have in our nationwide study. And actually, it's quite interesting, but I found exactly the same risk estimate also as in our nationwide study. And adding all the lifestyle information, so this includes both smoking, a number of diet information, alcohol, physical activity, it really didn't change the risk estimates. So it indicates that adding in lifestyle it is not an explanation, at least, to our results. So a bit on dementia, where we also did a study. And if you look on these curves, in pink, again, the most exposed facade. In blue, the least exposed facade. You can see it has this really strange leveling off, especially those at the least exposed facade. So because this curve is not at all linear, we didn't do any linear estimates, but we did categorical estimates, and you can see here. And as you can see, we found a bit stronger association for noise at the least exposed facade, which again fits nicely with our hypothesis that it was an effect through sleep. But we thought it would be interesting to try to look more into why we have this strange leveling off. And we did that by looking at the association according to different population densities. So we looked at it in rural areas, in urban areas, and in suburban areas. And if we start with the rural areas, you can see here in the rural areas, we don't see this leveling off at all. But if you look at the really high urban areas, this orange line, you can see we have this strange leveling off here. So what we think might be happening here is that in these urban areas, we will have this masking of traffic noise by other types of noise that are really highly present in cities. This includes, of course, neighborhood noise, which a lot of people complain on. It can be people talking in the street, all different kinds of noise that we have no idea of in our model, so we cannot control for these. So these may be masking our results. So it is possible that if we had information on these, we would actually see the curve continuing. So if we were able to control for this, it could also be that people living in high urban areas do better sound insulation, not only because of the road traffic noise, but also because of all the other noise that they're exposed to. So to breast cancer, this is the last study I will show you. Here, of course, we focused only on women. And we had a population, therefore, on 1.8 million and 66,000 cases. And we started looking at noise at the most exposed facade. We found relatively weak hazard ratios here, risk estimate. There were an indication here on higher risk at higher levels. But when we looked at noise at the least exposed facade, this indicator for noise during nighttime, we found a stronger association, and you can see here at higher levels, we found a nice dose-response relationships. And this fits nicely with other studies that have been conducted later on that have shown that noise may have an effect on the circadian rhythm, because we know that disrupted circadian rhythm is a risk factor for breast cancer. For example, in nurses which have shift work noise, we know that there are higher shift work, that there are higher risk for them to have breast cancer. So what is the status here, June 2025 on this area? For cardiovascular disease, we know that there's an association with ischemic heart disease. This was what the WHO concluded, and this has been only confirmed later on, but both for disease and also for death. It's highly likely associated with stroke. There are a number of studies, not only the ones I showed here, but there's also a number of other studies showing an association. Highly likely an association with heart failure. Here we also have a number of studies showing this, and with the type 2 diabetes. So if I were to do a health impact assessment tomorrow, I would actually include these 4 different diseases. There are also a number of studies that have shown an association with overweight. I didn't show that, but they are also really pointing in one direction, these studies that have been investigating noise and overweight. And then there are these number of diseases that I hope many of you will do a lot of research in the future, where we really still lack evidence, which includes breast cancer, dementia, depression, respiratory diseases, reading comprehension, hypertension, tinnitus, and I'm sure the list is longer. So if you're interested in noise, you can see here that there's a lot to do in the future. So my last slide here is the discussion. Things I think that is important for the future that will be discussed, and this is we need to find the lower harmful threshold for noise. So from where is noise harmful? Right now, EU is only calculating noise for more than these 55 decibels. So I think we have to discuss now whether it's the correct way of doing it, because if we go down, as our studies show, we will actually, in calculation of health impact, find a number of more cases. Also, it's important to, again, discuss, as I said, which studies to include when we do health impact assessments. And then all of you, when you conduct studies on noise, I really urge you to do high quality estimation of noise. If you use, for example, the END noise calculation, you can see that there are these large black dots on the map where noise are not estimated, or at least if you use these, be aware of the limitation and highlight this in your papers so that we know this. Yeah, thank you to all these persons that helped me do all this. And I think, Benedict, now I'm done. Thank you for being here.
Thank you very much, Mette, for this very comprehensive talk. Are there any questions from the audience? Please raise your hand and you will be given a microphone.
Many thanks, Mette, for this very nice presentation. I'm here.
Okay.
This is Kayam Dadwan from ISEE Global, and I'm really amazed by the work that you are doing there. And my question is that, I mean, for some of your outcomes, you saw perhaps a stronger association for the more silent part, rather than the high exposed facet. And what would be the explanation for this stronger association that you see for that?
Yeah, actually, it's really interesting because for the cardiovascular diseases, it seems to be a stronger association with the most exposed facade. So that indicates that for cardiovascular disease, which also actually makes sense, this effect on stress, activation of a stress response is very important. Whereas for diabetes, where we know that effects on sleep are really important, which is the least exposed facade, dementia, we also expect sleep to be important. Breast cancer, where we expect this effect on sleep to be important, that we see that this least exposed facade is stronger associated. So basically it follows our a priori hypothesis pretty well. So it might even be that it's, that we really need to look into this in the future on where do we actually experience the noise, because it may differ for different diseases even.
Perfect, many thanks.
And I think we had a question.
Hi, good morning. My name is Enoch, and I'm a researcher from the University of Leicester. Thank you for a wonderful talk. My question is around the noise modeling. I found the way you guys do it's really interesting with the way with the reporting of a 10-year time weighted. Could you maybe speak on that, as in how do people base model noise over time? Do you capture noise during different periods of time? Thank you.
Yes, Good question. I didn't have time to go into detail, so I'm really glad you asked this. So what we do in our model is that we look at these time-weighted averages, meaning that, for example, if a person get a disease, let's say diabetes, when he's 70 years, we take into account noise for the last 10 years. So also if the person's actually changed address over the last 10 years, we take this into account, and then we do an average the last 10 years before the diagnosis. And then we compare with all other persons that are 70 years of age in the population, but do not have diabetes. And then we also calculate 10-year averages for them. So to estimate if there's any difference. So this is how we handle it in the Cox regression model.
There is another question all the way.
Hello. Well, thanks, Mette, for this fantastic work that you're doing and the wonderful presentation. I'm Barbara Hoffmann from Germany. I'm wondering, you've been using the least exposed facade as a proxy for the nighttime exposure. Could you, I mean, there's also studies that have a night as nighttime exposure. Could you expand on the pros and cons of using a night versus the least exposed facade?
Yes. We also have L night in our data, but we have a correlation between L day and L night on 0.999. So we're not able to separate these. So at least for road traffic noise, the way that these acoustical models estimate road traffic noise with the same input data, of course, different for day, evening, night, but they end up in most models coming up really correlated, meaning that you really can't separate night and day. This is for road traffic noise. I think for if you have good aircraft noise data, it would actually be really interesting to look at nighttime noise also, because you would see a larger difference actually there, a less correlation. So it may be different, and also for railway noise, but for road traffic noise, it's really, really difficult for us to separate exposures during day and night. And this is why we ended up doing this with the least exposed facade, because we there tried to go on the other side of the building and estimate noise where people were more likely to sleep.
I think maybe one more quick question, but then I think we should move on to.
I'll make it quick. Bruno Kreeft from the Netherlands. Thanks for a very nice presentation. You showed the leveling off for dementia. And then you had some speculations about why that might be. Community noise, maybe extra noise cancellation measures. Shouldn't those affect the effects on heart disease as well? Because this should affect everything and not just dementia. In the lab study, we saw a leveling off of concentration response functions repeatedly. But we also saw that at the high exposure levels, the confidence intervals become very wide. So we didn't pay too much attention to that actually in the lab study. So I was wondering what your thoughts are.
We see it, I agree. It's also something we have been wondering, because in some of our study, we don't see, for example, for the diabetes study, we saw this really nice continuing association. And here we would also expect basically the same, but we didn't see it. We saw some of the same for stroke. So sometimes we see it, sometimes we don't see it, but especially for dementia, it was just so really marked that we didn't think that it was even okay to do linear estimates, and we didn't see this previously. I don't know why it seems to be more relevant for dementia. I don't know, maybe these persons are have a different behavior than the other diseases that we have been looking on. Maybe they stay more home, I don't know, but at least it's just really marked for these dementia cases compared to what we saw in the other studies. I have no better explanation.